Hi everyone, on today's podcast, we're going to talk about the evidence on IV fluids during labor. Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Dekker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See evbirth.com/disclaimer for more details. Hi everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. My name is Dr. Rebecca Dekker, pronouns she, her, and I'll be your teacher for today's episode. Today, I am excited to bring some brand new evidence-based information to you. Last month, we hosted a podcast all about updates we made to our research article on eating and drinking during labor. That was episode 233 of the EBB podcast. And today, I'm excited to expand your knowledge on a closely related topic, and that is the evidence on IV fluids during labor. First of all, I want to remind you that eating and drinking during labor is normal or physiological, and that it's not evidence-based to require someone to fast or restrict their eating and drinking during labor. One of the major reasons that most people have IV fluids in labor is because they're not allowed to eat or drink. I'm going to touch on that a little bit today, but if you want more information, you can check out episode 233 of the podcast, and you can also read the full Evidence-Based Birth signature article on eating and drinking during labor at evidencebased.com/eating. We also have a published signature article on IV fluids during labor available at evidencebased.com/IV fluids. That's all one word, IV fluids. We are in the process of publishing updates to that article, and those updates should be posted this month. But today you're going to get all of the evidence on IV fluids during labor, including the newest research. So are you ready to get started? Okay, let's dive in. So how many people have IV fluids during labor? Well, we only have information on this topic from the United States. And the latest national survey from the United States, the Listening to Mothers 3 survey published by Dekker et al. In 2014, found that most people, or 62%, received continuous drip, intravenous, or IV fluids during labor. A more recent survey of California hospital births, also published by Dekker et al. In 2020, found that 76% of birthing people received IV fluids during labor with midwives versus 87% of birthing people who had an obstetrician attend their births, and that was significantly different between those groups. Labor is considered by many people to be a demanding exercise. It's where a large muscle in the body, the uterus, is working over many hours. But many people around the world are not allowed to eat or drink during labor. This is often called NPO or nil per os, also translated as nothing by mouth. Because it's necessary to stay hydrated during labor, IV fluids are usually administered to people who are NPO or not allowed to drink. However, if you go back and read the Evidence-Based Birth signature article on eating and drinking during labor, you will find that the practice of forbidding food and drink, while common, is not evidence-based. The nothing by mouth policies during labor originated in the 1940s, and they were based on doctors' fears that a person will inhale or aspirate stomach contents while they're under general anesthesia, which they used to give everybody or a lot of people general anesthesia during vaginal births, or perhaps if you general anesthesia during an emergency cesarean. However, the increase in the use of epidurals and advances in surgery and anesthesia have made aspiration almost unheard of today. The American College of Nurse Midwives, the World Health Organization, the National Institute for Health and Care Excellence in the United Kingdom, and the Society of Obstetricians and Gynecologists guidelines in Canada all recommend that people be allowed to choose whether or not they want to eat or drink during labor. So if people should be able to eat or drink during labor, then are IV fluids necessary? Well, let's talk a little bit first about what are intravenous fluids. So speaking as someone who used to work in the hospital as a staff nurse, I can testify that many hospitalized patients receive IV fluid therapy. This is usually done with the purpose of maintaining adequate hydration when oral fluids are restricted. Now, when you're working in labor and delivery, the three most common IV solutions for people in labor are normal saline, something called Ringer's lactate, and dextrose solutions. And dextrose solutions contain a type of sugar from corn or wheat that is almost identical to glucose. For how common these fluids are and how often they're used in labor, surprisingly little research has been done to compare the different types of IV fluids. Another important thing you need to know when you're administering IV fluids as a nurse is we learn about something called fluid volume overload, also known by the medical term hypervolemia. Fluid volume overload can happen when there is too much fluid in your blood. With hypervolemia, extra fluid can collect in the lungs and other bodily tissues, and the heart has to work harder to pump the extra fluid around the body. Fluid overload is more common with IV fluids than oral fluids. Because with IV fluids, the fluid is going directly into the bloodstream. It's inserted into your vein instead of traveling through the stomach and intestines first. This overrides a healthy body's ability to maintain fluid balance. So normally when you're eating and drinking, your body uses the gastrointestinal system and the kidneys to maintain fluid balance. So when you're giving it just straight through the vein, you're kind of bypassing the whole gastrointestinal system. Overload is not likely to happen in young people with healthy kidneys that can process the extra IV fluids by getting rid of them through the urine, and if you have a healthy heart that can easily pump the extra blood volume. However, hypervolemia or excess fluid volume can still cause issues with swelling or maybe discomfort from swelling of your tissues if it takes a little bit longer for your body to get rid of the extra fluid. So what is the research evidence on giving IV fluids during labor? Well, we found 3 meta-analyses, which are studies that combine data from many similar studies, and they were all focused on IV fluids during labor. And those 3 studies were first, 2013 Cochrane Review, where they combined 9 randomized trials and looked at results with a total of about 1,600 people. These researchers were interested in whether or not routine IV fluids could make labor shorter, and they also looked at how IV fluids might affect birth outcomes like cesareans or the number of babies that are admitted to the NICU or the APGAR scores of the new babies. The second meta-analysis, which I'll refer to as the 2017 meta-analysis because it was published in 2017 by Esenapor et al., they included 7 randomized controlled trials with about 1,200 people, and they studied the relationship between IV fluids and birth outcomes, but they were mainly interested in the relationship between IV fluids and the cesarean rate. Finally, there was a meta-analysis published by Regal et al. In 2018, where they combined 16 randomized controlled trials with about 2,500 participants to examine whether dextrose IV fluids, that's IV fluids with a little bit of sugar in them, could shorten the length of labor. So all of the studies included people who were low risk, and the 2 of them only included people in spontaneous labor. So these were people who did not have an induction, and some of them only included people giving birth for the first time. None of the studies reported on patient satisfaction, none of them reported on levels of dehydration, and none of them measured breastfeeding or chest feeding rates or the effects of IV fluids on whether or not the newborn loses weight from fluid weight in the first day or so of life. And we'll talk more about that in a little bit. So let's first focus on the results from these meta-analyses when they compared people who got IV fluids and oral fluids versus those who got oral fluids alone. Actually, very few researchers have ever compared IV fluids to oral fluids alone. And that in itself is very revealing because IV fluids are so common during labor that when they're studied, it's usually to compare like one IV fluid to another or one rate, like how much are you giving of IV fluids to one group versus the other group. In fact, we found that only 3 times in history have researchers ever compared IV fluids to drinking oral fluids. And in all 3 studies, people in the IV fluids group were also permitted to drink oral fluids. So we've got IV fluids and oral fluids versus oral fluids alone. In the first of those 3 studies, This one was published by Cavitha et al. In 2012. They randomly assigned 293 people in labor to one of three groups. They were either given oral fluids alone, which included plain water and coconut water, oral fluids plus IV fluids at 125 milliliters per hour, or oral fluids plus IV fluids at 250 milliliters per hour. They ended up finding no differences between the three groups in terms of the length of labor, the number of cesareans, the number of people who got Pitocin augmentation, or any other complications. There was a lower chance of vomiting in the group that had more IV fluids. So only 6% of people in the 250 milliliter per hour group vomited during labor. 11% vomited in the 125 milliliter group, and 24% vomited in the oral fluid group. This is not surprising given that keeping people hydrated with IV fluids when they're at risk for dehydration is one way you can lower the chance of nausea. For example, if you've ever had outpatient surgery or inpatient surgery, sometimes they'll give you IV fluids after the surgery to kind of help lower your chance of vomiting. In the second study, 120 people were randomly assigned to either oral fluids alone, and that included water or soda, or they could be assigned to have oral fluids plus IV fluids at 60 milliliters, 120 milliliters, or 240 milliliters per hour. This study was published by Dirikvand, Mogadam, and Razian in 2012. The researchers found that people who did not receive any IV fluids had longer labors. Also, Pitocin augmentation was used more frequently in the group with no IV fluids. But they didn't find any differences between groups in terms of cesarean rates, vomiting, or low APGAR scores in the babies. When these two studies were combined in the Cochrane review, the Cochrane researchers found that people who received IV fluids plus access to oral fluids had shorter labors by about 30 minutes compared to those who had oral fluids alone. And there was no difference in cesarean rates or APGAR scores for babies. I want to remind everybody, though, that in both of these trials, the people who received IV fluids were permitted to take in oral fluids. In the first trial, they reported the average amount of fluid intake per group, and they found that people only took in about 900 milliliters during labor if they had oral fluids alone, 730 milliliters if they were getting oral fluids plus IV fluids at the rate of 125 an hour, and 1,300 milliliters for those who were receiving IV fluids at 250 milliliters per hour. The oral fluids group that only got oral fluids experienced the greatest fluid loss due to vomiting. I contacted the authors for more information and found out that the oral intake in the people in the IV fluids group was not documented because they drank so little. Another trial did not report the total amount of oral fluids received in each group, but they did determine that the IV fluids drank just as much fluid orally as the oral fluids only group. So when you're giving oral fluids and IV fluids in this study, it makes sense that they are taking in more, they're less likely to get dehydrated, and sometimes they had less vomiting. They also had shorter labors by about 30 minutes. This suggests that mild dehydration could contribute to slightly longer labors. It also might suggest that people who are not receiving IV fluids might need support and encouragement to drink enough to stay hydrated during labor. It might not be enough to just rely on whenever you feel thirsty, because you might be distracted by the work of labor, and so you might need reminders from your support team to take sips of whatever fluids you're drinking. A third trial was too recent to be included in the Cochrane review, and they were comparing two different types of IV solutions plus oral fluids versus oral fluids alone. And this was published by Ahadi Yogunlu et al. In 2020. These researchers were interested in whether the type of hydration affected the length of labor in low-risk people giving birth for the first time. So these people were all first-time birth givers. They were all in spontaneous labor. They were all at least 4 centimeters dilated. The people receiving IV fluids were given it at a rate of 125 milliliters per hour. Subjects were blinded to the type of IV fluid they were receiving, and everyone, regardless of which group they were put in, was free to drink liquids such as water, orange juice, or apple juice. The two different types of fluid that they were comparing were Ringer's solution, lactate Ringer's, versus a 5% dextrose solution. The researchers found that people receiving the IV fluids with dextrose had significantly shorter labors on average compared to the other groups. The average length of total labor was 525 minutes with oral fluids alone, 300 minutes with ringer solution plus oral fluids, and 172 minutes with dextrose solution plus oral fluids. They also observed a significant decrease in the length of the active stage of labor and the third stage of labor in people who received dextrose in their IV fluids, but no difference in the pushing phase of labor. In addition, the people in the dextrose group used less Pitocin augmentation and had a lower rate of prolonged labor. These researchers did not report the amount of oral fluids consumed by each group or the amount of water that they drank versus how much did they drink of carbohydrate-containing fluids. So if the oral group is drinking mostly water in small amounts, maybe that outcome would have been different if they had been taking in more fluids, especially fluids with oral carbohydrates. But I think it's interesting that these benefits were seen with the dextrose IV solution because they suggest that you could possibly achieve something similar if you're being given or you're taking in a sufficient volume of oral fluids that contain carbohydrates or sugars. But we really need more research to better understand this. Next, let's talk about comparing IV fluids at different rates. So in the Cochrane review, they also looked at people receiving 125 milliliter per hour fluids or 250 milliliter per hour fluids in addition to being able to drink freely. So in this category, they looked at the previous two studies and they added one more. In the additional study done by Coco et al. In 2010, researchers randomly assigned 80 people in labor to receive Ringer's lactate at 250 milliliters per hour or, quote, usual care. Usual care was defined as the person would receive IV fluids if the healthcare provider thought it was needed for medical reasons. The people in the IV fluids group received an average of about 2,600 milliliters of IV fluids, and those in the usual care group ended up receiving about 1,600 milliliters of IV fluids over the course of their labor, which worked out to approximately 125 milliliters per hour. People in both groups were allowed to drink as much as they desired, such as water, juice, or soda, and both groups drank similar amounts. There were no differences between groups with regard to total labor length, length of each stage of labor, cesarean rates, augmentation rates, or any other outcome measured. When these three trials were combined, the Cochrane researchers found that shorter labors happened by about 24 minutes on average, and people who received the higher rate of IV fluids at 250 milliliters per hour compared to those who received IV fluids at 125 milliliters per hour. And they found no difference in the cesarean rates or anything else. So this is, again, additional evidence that people without IV fluids or those who receive IV fluids at a lower rate, just 125 milliliters per hour, may need some active encouragement to drink enough oral fluids to maintain adequate hydration. And if they don't, they might have a slightly longer length of labor. Now let's look at the evidence for nothing by mouth and IV fluids at different rates. And what we're going to find is that the nothing by mouth policy and IV fluids at a lower rate is a recipe for getting dehydrated during labor. So there were 4 trials that compared different rates of IV fluids and people who either had 0 oral fluids or ice chips only, or they were only permitted occasional tiny sips of water. And these studies were carried out by the research groups of Garite et al., Alavi et al., Islamian et al., and Medaria et al. This means that none of the participants in the studies were allowed to drink freely. And this is unfortunately similar to what we see in many hospitals around the world today. So when the Cochrane reviewers combined the results from these 4 trials, they found longer labors by about 1.5 hours in the people who received the lower IV fluid rate of 125 milliliters per hour. And the shorter labors happened in people who were receiving IV fluids at 250 milliliters per hour. They also found a higher risk of cesarean in the group that received the lower rate of IV fluids. So there was also the 2017 meta-analysis. They combined 7 trials and they found consistent results. So similar to what they found in the Cochrane review. And They found that labors were longer by about 1 hour when people who were not allowed to drink anything had IV fluids at the lower rate. They also found a higher risk of cesarean in the group that had IV fluids at the lower rate. Now remember though that these findings cannot be applied to people who are allowed to drink freely, since most people included in these studies were under very strict oral intake policies and were not allowed to drink anything. Next, let's talk about the evidence on dextrose IV fluids. So since muscle performance when you're exercising is improved with carbohydrate replacement, researchers have hypothesized that replacing carbs during childbirth might help your uterus contract more efficiently, more strongly to help speed up labor. So in 2018, Regal et al. Published the first meta-analysis to study randomized trials that looked at comparing IV fluids with dextrose versus those IV fluids with no dextrose. And they included 16 randomized controlled trials with a total of about 2,500 participants. Only one of those studies allowed participants to eat and drink during labor as desired. Most of the studies used a type of IV fluid with dextrose called 5% dextrose. 4 studies gave at least some of the participants 2.5% or 10% dextrose. In the no dextrose group, which was considered the control group, the studies used normal saline solution or Ringer's lactate. The IV fluids were given at different rates, ranging from 20 milliliters per hour all the way up to 300 milliliters per hour. And they were usually started during, quote, active labor, which was defined differently in different studies. So the people who were randomly assigned to dextrose IV fluids had a shorter first stage of labor by about 1 hour and 16 minutes on average, compared to those who did not get the dextrose IV fluids. There were no differences between groups in the cesarean rate or infection rates or rates of heavy bleeding after the birth. And there were no differences in newborns who were admitted to the ICU or who had low APGAR scores. Another thing that some of the researchers looked at was low blood sugar in the babies. And they did find a trend towards a higher rate of low blood sugar in babies whose birthing parents received dextrose IV fluids. The rate of low blood sugar in those babies was 5.7%. compared to 3.2% in the group that was not exposed to IV fluids with dextrose during labor. The authors cautioned that it would be wise to observe newborns who are exposed to IV fluids with dextrose for signs and symptoms of low blood sugar until more research confirms whether this risk actually exists or not. The concern here is that dextrose IV fluids during labor could cause high blood sugar in the birthing person, leading the baby to compensate during labor by secreting more of the hormone insulin, which then could lead to higher levels of the fetus with insulin. And then after the umbilical cord is clamped, the source of incoming sugar is cut off, and then the newborn can experience low blood sugar. However, as I mentioned earlier, more research is needed to study this effect. The American Journal of Obstetrics and Gynecology Maternal Fetal Medicine published a recent review of evidence-based labor management guidelines by Al-Hafez and Bergella in 2020. And those authors made a strong recommendation that if fluids are restricted and somebody is not drinking oral fluids, that IV fluids at the rate of 250 milliliters per hour containing dextrose are recommended. Now let's talk about IV fluids and the potential impact on breastfeeding or chest feeding. So the studies that we've been looking at have mainly focused on the risks of dehydration and whether dehydration can lead to slower labor and increase the cesarean rate, which it seems that it does. But on the other end of the spectrum, if you have too much fluid, as we mentioned earlier, that's called fluid volume overload or hypervolemia. This can cause painful swelling called edema and excess fluid in the new baby at birth, potentially leading to feeding complications when the newborn's weight at birth is artificially inflated. As shown in movies and TV, newborns are often weighed within minutes of birth, although many hospitals are delaying this for the first golden hours so that you can bond with your baby. But new babies are often weighed very early after birth. And that measurement becomes the baseline for assessing how much weight does the baby lose in its first days of life. So there are clinical guidelines on newborn weight loss, and they caution that if you lose more than 7% of the baby's body weight from birth to 3 to 5 days of age, that's a sign of ineffective feeding that might mean that you need to supplement with formula. However, research suggests that because of IV fluids, some newborns are born with a fluid overload, which causes them to weigh more when they're born. And the resulting correction of fluids that their body naturally does, they naturally urinate off that extra fluid, can lead to a concerning weight loss when what is happening is just the normal correction of their fluid status. So in 2012, researchers led by Watson et al. Did the first randomized control trial on this topic. The people in the study were all low-risk birthing people. They were not allowed to eat or drink, and they were planning to have epidurals, and they were all planning to breastfeed. Half of the study group, so about 100 people, were randomly assigned to lower amounts of IV fluids, which meant they got less than 500 milliliters before they received an epidural, and they got an hourly rate of 75 to 100 milliliters per hour after the epidural. Another 100 people received higher amounts of fluids, meaning they got more than 500 milliliters before the epidural, and then they had an hourly rate of more than 125 milliliters per hour afterwards. On average, people in the lower amount group got about 1,400 milliliters, and the higher amount group got about 2,400 milliliters, so about 1,000 milliliters or 1 liter more on average in the higher volume group. In contrast to other studies that found that the higher amount of IV fluids shortened labor, this study did not find a difference in the length of labor between the two groups, and there was no difference in the percentage of people who got a cesarean either. In this study, the authors defined excess weight loss in the newborn as losing more than 7% of your body weight at 48 hours after birth. When the researchers compared the two groups, they did not find a difference in the number of breastfed newborns who experienced excess weight loss. However, they did find a greater weight loss in the infants born to people who received more than 2,500 milliliters of IV fluids. They also found that a higher volume of IV fluids was given to the parents of the babies who lost more than 10% of their body weight. This research study suggests that once you receive around 2,500 milliliters or higher of IV fluids, it will affect your newborn's weight after birth and their weight loss. So the authors recommended replacing a 7% weight loss with a higher percentage, since almost half of the infants in the study who were breastfeeding or chest feeding lost 7% of their birth weight. In support of that, a systematic review by D. Tommaso et al. In 2019 found that weight loss among newborns is often 7 to 8% of birth weight or greater by the third day of birth among healthy full-time newborns who are breastfeeding or chest feeding. And most of these newborns regained their lost birth weight by 14 days after birth. We also have several observational studies that looked at the relationship between IV fluids and newborn weight loss, and they found pretty interesting results as well. There was a recent study published by Giotticelli et al. In 2022. They looked back at the records of 150 people who were giving birth to healthy babies at term after a low-risk pregnancy. All of these babies were exclusively breastfeeding at hospital discharge. And the researchers found that the newborns whose birthing parents received 1,500 milliliters or more of IV fluids during labor lost significantly more weight until the third day of birth compared to those whose parents received less than 1,500 milliliters. An earlier study published in 2010 by Chantry et al. Followed 448 people through pregnancy and after birth to look at risk factors for excess weight loss in newborns. And they define excess weight loss as more than 10% loss of birth weight at 3 days of age. Of the breastfed and chest-fed newborns, 16 to 19% experienced excess weight loss. And the only two things that predicted which babies would experience excess weight loss were higher amounts of IV fluids given during labor and delayed milk production. If birthing parents received more than 200 milliliters per hour of fluids during their labor, their babies were more than 3 times more likely to experience excessive weight loss at 3 days compared to those who received less than 100 milliliters per hour of fluids. The babies whose parents had taken in more IV fluids were also found to urinate more during the first 4 hours of life. It makes sense. If you take in a lot of fluid, you're going to urinate out a lot of fluid. And more than half of the infants in this study were supplemented with formula, even though their parents were intending to breastfeed or chest feed. And the main reason for supplementation was excess weight loss, along with concerns about a delay in mature milk coming in. Other researchers have shown that reports of excess weight loss in newborns can trigger a new parent's anxiety about their milk supply, which is then associated with a higher risk of stopping breastfeeding or chest feeding. In a smaller study, a different group of researchers, Noel Weiss et al., found that higher amounts of fluids during labor were associated with excess weight loss in newborns. And these authors suggested an alternate solution, which is that you use the 24-hour birth weight, not the birth weight, as the baseline to track the infant's weight over time. This gives time for the newborn baby to urinate off the excess fluid from the IV fluids and get closer to what would have been their real birth weight. Another factor or way that IV fluids might interfere with breastfeeding or chest feeding is through chest swelling. So there was a study done in Canada by Kujawa Miles et al. In 2015, where they found that 87% of birthing parents initiated breastfeeding or chest feeding, but 21% of them had stopped by 1 month. When they were asked about early weaning, parents frequently cited sore breasts, chests, and sore nipples. So the researchers conducted a small observational study to look at IV fluids during labor and see if that could be contributing to postpartum chest swelling. In this study, there were 17 first-time birthing parents, and 13 of them had received IV fluids during birth. Participants received an average amount of 2,800 milliliters total during labor, which is a pretty high amount. The researchers found that people who received higher amounts of IV fluids during labor reported more postpartum chest tenderness on a self-assessment scale and had more chest or breast firmness when palpated or touched by the researcher. We need more research on this subject, but the bottom line on the topic of IV fluids and breastfeeding or chest feeding is that higher amounts or very large amounts of IV fluids can potentially harm the breastfeeding, chest feeding relationship by contributing to excess newborn weight loss and by possibly leading to painful swelling in the postpartum parent. So now let's sum up what we found about IV fluids. There are mixed findings from the research, but evidence has been building over the years that dehydration and a lack of carbohydrate replacement is related to having a longer labor. Being adequately hydrated may help people to experience a shorter labor by anywhere from 30 minutes in some comparison to 90 minutes in other comparisons. People drinking freely without IV fluids or those who receive IV fluids at a low rate may need encouragement to drink enough oral fluids to stay hydrated. One of our research team members at EBB asked me, how often do you need to be drinking and at what amount? So I simulated an hour of labor with contractions occurring every 5 minutes. I basically started a timer on my phone and had it go off every 5 minutes. And that would be the start of contraction to the start of the next. And I tried taking 1 gulp of oral liquids after each contraction, or fake contraction, I guess. So during this frequency of contractions that were happening about every 5 minutes, which is pretty standard for active labor, I was able to maintain a fluid intake of about 1 cup, which equals 240 milliliters per hour. But of course, that's only because I'm not vomiting. If I was vomiting, then I would need to drink more to make up for the fact that I was losing fluids. Another way to make sure you're drinking enough fluids, so if you're aiming for 240 milliliters or about 1 cup of fluids per hour, you could have your support person pour about 1 cup of liquids or 240 milliliters of liquids at the start of the hour. Or you could track it with one of those water bottles or measuring cups that kind of marks how much fluid you've drinking, and make sure you're finishing that much every hour. A regular urge to urinate and clear or pale yellow urine can also help you know that you're staying hydrated. It's also important to know that when people are not allowed to drink freely in labor, and they're receiving IV fluids at a lower rate, that they're at increased risk of having a longer labor by about 1.5 hours on average, and they're more likely to give birth by cesarean. However, no organization that I know of recommends restricting people to ice chips or sips of water. So any hospitals that still have policies forbidding oral fluids, even if you have an epidural, these hospitals are out of line. They are not following both current evidence and professional guidelines. I want to mention that IV fluids containing dextrose also appear to shorten labor. However, babies that are exposed to dextrose-containing fluids might need to be observed for signs and symptoms of low blood sugar after birth. There's increasing evidence that although large volumes of IV fluids during labor may shorten your labor and possibly reduce the risk of cesarean in a hospital birth, a higher amount of fluids, meaning you have more than 2,500 milliliters during the course of labor, could lead to an artificial drop in your baby's weight after birth and possible painful chest swelling, both of which can harm breastfeeding or chest feeding. Our bodies are normally maintaining a delicate fluid balance, and that balance needs to continue during labor and afterwards. You can get dehydrated if you're not drinking enough, if you're vomiting too much, or you're not receiving enough IV fluids. On the other hand, you can experience fluid volume overload if you're receiving too great a volume of IV fluids. When you're in labor, you should be encouraged to drink enough to stay hydrated, and the use of IV fluids can be guided by your unique situation, needs, and preferences. There are many different examples of medical reasons for IV fluid therapy. For example, you may need IV fluids during labor if you're experiencing nausea or frequent vomiting or diarrhea, exhaustion if you're having a prolonged labor, if you have low blood pressure due to epidural side effects, if you've lost blood volume, and if you need IV fluids to help deliver and manage medications. Obviously, one alternative to having IV fluids is to not have an IV at all. Another option would be to have a saline lock. That's when you have IV access, but you're not hooked up to the tubing with IV fluids. So we do have a podcast episode on that. To learn more about the evidence on saline locks, also sometimes called heparin locks, just go to Evidence-Based Birth Podcast, episode 104. And finally, I thought it might be interesting to end with some of the guidelines on this topic. The World Health Organization urges against the routine use of IV fluids during normal labor and birth. They caution that restricting oral intake and not allowing people to drink fluids can lead to dehydration and exhaustion, and they propose that people be offered drinks and light meals during labor. The American Congress of Obstetricians and Gynecologists affirms that low-risk birthing people should be encouraged to have clear liquids during labor to meet their hydration and calorie needs. They point out that routine continuous infusion of IV fluids may offer no benefit to people in spontaneously progressing labor, and it may harm freedom of movement because you're tethered to an IV pole. One more related topic is you might want to check out our evidence-based birth signature article on failure to progress. That's available at evidencebasedbirth.com/failure to progress, and it talks about prolonged labors. And you can find all of the citations for all the scientific studies I referenced in this podcast episode, as well as links to the actual studies themselves by going to evidencebasedbirth.com/IV fluids. Thanks everyone, and I'll see you next week. Bye. Today's podcast was brought to you by the signature articles at Evidence-Based Birth. Did you know that we have more than 20 peer-reviewed articles summarizing the evidence on childbirth topics available for free at evidencebasedbirth.com? It takes 6 to 9 months on average for our research team to write an article from start to finish, and we then make those articles freely available to the public on our blog. Check out our topics ranging from advanced maternal age to circumcision, due dates, big babies, Pitocin, vitamin K, and more. Our mission is to get research evidence on childbirth into the hands of families and communities around the world. Just go to evidencebasedbirth.com, click on blog, and click on the filter to look at just the EBB signature articles.